Okay, well, thanks for inviting me to talk. And I'm going to talk about rare melanomas. So it's changing the tack from the skin melanomas, which I guess most has been covered in most of the talks up till now. My name is Neil Stephen. I'm a medical oncologist. I'm based here in Birmingham, so I've not had very far to come. And a bit like some of my other colleagues who in the room have mentioned, we have a very active multidisciplinary team, which is, I'm pleased to say, very functional, and have access to the full range of services in Birmingham, including things like CyberKnife, etc. So it's kind of replicated around the country, the access to these services. When I came into melanoma, when I came in somewhat longer ago than the previous speaker, when I came in, it looked a bit like this. So on the one hand, it's skin melanomas, and then on the other side, there's all the other stuff, which the team largely ignored because it was the thing that didn't belong to the dermatologists. So so there was a lot of subdivision of skin melanoma into different groups, largely based on its physical appearance. But in that mix, there was this particular kind of skin melanoma called acral, which appears on the non-hair-bearing parts of the skin. And that's an unusual pattern of melanoma, so it's much less common than the other forms. And then there are also melanomas that appear in the eye and others that appear in mucosal sites. So this means in the head and neck, particularly in the sinonasal region, other parts of the upper airways, much more rarely as part of the airways, actually in the lungs themselves. Melanomas appearing in the female genital tract, and also in the anus and rectum. And then there are much rarer melanomas appearing within the other parts of the gastrointestinal tract. You can get it in the esophagus as well. I've got a patient at the moment with that, but these are much rarer. So these patterns have been recognized, but are much less common than skin melanoma. So building pathways for those patients has been more complex. I'll just talk particularly about I should go back in terms of the distribution of those. The airways, the upper airways, are the most common of the mucosal melanomas, and then it's roughly split in terms of the female genital tract and the gastrointestinal tract, which are around about a quarter or a fifth of those mucosal melanomas. To explain the patterns in eye melanoma needs this diagram. And so what we're talking about is this bit called the uveal tract, and I don't know whether there's a laser. There's a laser. Yes. So what we have is this bit here marked in red, which is this vascular area here called the choroid, and it goes right down, forms part of the ciliary body, and also the iris at the front of the eye. So that's the uveal tract, and that's where ocular melanomas typically develop, that you can get melanomas on the front of the eye, on the conjunctiva, but those behave much more like skin melanomas. They're not really the same as the uveal melanomas. And you'll find that I keep talking about uveal melanoma or ocular melanoma through this, and I mean the same thing by those two terms. And you can see that the bulk of them are occurring in the uvea, in this bit, and then the conjunctival are much less common. Another thing to notice there is some of those bits are susceptible to ultraviolet light and to light exposure at the back of the eye. The bits at the front of the eye actually don't get much light because they face the other direction. So if we go back to this diagram and look at this, the point I want to try and get across here is that melanoma is not the same condition across different anatomical sites. That's probably the single most important point to make. And you might think that's obvious, but actually it hasn't been obvious in the way that that doctors really have approached this, not recently, but longer term, that the other melanomas, the non-skin melanomas, are rare, so therefore they have tended to be treated a bit like skin melanomas for lack of any other good evidence. And the point I want to get across here is how different they are. And so you start seeing this anyway, because if you look at the skin melanomas, they split up and you can see slightly different patterns in terms of anatomical distribution and their relationship to sunlight-induced damage in the skin. So there are already variations in that population. But then the acral ones, the ones on the non-hair-bearing skin, they're in a different age population. You can see it's an older group of patients. And the mucosals, again, slightly different age population. And you can see an ethnic association with this, so that cutaneous melanomas are very much cancers of white skin population. And that really means, but what I mean by that, I mean, we have to remember that white has biological and also cultural associations, but what I'm talking about here is biology. And what we're talking about here is a population that originates in Northern Europe, particularly, and that the risks in people whose skin may look white, but actually originate in Southern Europe or in parts of India, have different risks for melanoma than populations originating in Northern Europe. So these are very much conditions of white people, whereas with the acral melanomas and the mucosal and the ocular melanomas, there's an increased risk in white people, but there's a much higher proportion of people with darker skins, and it varies across different ethnic groups. So it's less common in Asian populations, and then even less common in those originating from Africa. So, and you can get some idea about the incidence, and if you start doing the maths on what I've written there, you'll find it doesn't add up because they're pulled together from different sources. Ocular melanoma is treated by specialist centres, and I'm not going to be going into a great deal of detail about how the primary is treated, because actually that's outside my personal experience. I treat late-stage disease, but I want to say that there are very good rates, excellent rates, of local control that can be achieved for the ocular melanoma. But you can see that it's got a significant risk of developing metastatic disease, and that those disease sites are predominantly in the liver, but actually they're distributed across in the lungs and in the bones particularly, so that it's not just enough to look at the liver. You can see survival rates here, and those survival rates are obviously affected by risk factors. And again, I'm not going to go into those in great depth because they're particularly calculated by the ophthalmic surgeons and the original team who diagnose and treat the melanoma in situ, but there are risk factors relating to the depth of tumour and other features of the tumour that affect the probability of survival. And you can see that, unfortunately, when people do develop distant metastases, the probability of survival then drops quite dramatically, and that the median length of life is only just over a year, and the 2-year survival leaves only a small number of people alive. So this is a significant area of clinical need. If I flip over and talk about the mucosal melanomas, again, it is more challenging even than in cutaneous melanoma, so that the probability of 5-year survival is around 25% for all people with ocular melanoma, which is significantly worse than it is for cutaneous melanoma. So again, the mucosal melanomas are another area of significant clinical need. Now, what I want to do is to continue this theme about the biological variation between these types of melanoma, because it's the biology that underpins the success or failures of treatments and is going to drive the direction of future research. So this is what I want to really focus on now. And to do this, I don't know what your biological backgrounds are, and I'm sure it varies across the room. So if this is too noddy, then I apologise, but I have to go from somewhere. So on the left-hand side, we have a picture that you'll recognise as DNA, and the point about DNA is this double helix, but linking the two arms of the helix are these base pairs. And these base pairs effectively form letters in a language which codes for different proteins. And that's the way in which DNA broadly works. And so one kind of mutation is a variation just in the substitution of one of those letters. So a single nucleotide variation means one of those letters has been swapped for another one. Typically, the DNA has been damaged, and in the repair process, the repair has been faulty, and so a different letter has been inserted. So that's one kind of mutation. Another kind of mutation is much grosser. So in the other mutations, whole chunks of DNA are altered. So on the right-hand side, this is a crude representation of a chromosome, and a chromosome is DNA packaged up with other proteins into a much bigger structure. And you'll be aware that you get a chromosome from one chromosome of each kind from each of your two parents. So in this situation, I've drawn on here a cartoon region of DNA. So here we have a length of DNA here, and what you can see is you can have variations where that gets flipped over, or it can be deleted altogether, or you can get it duplicated, or the whole chromosome can be amplified and duplicated, or perhaps a chromosome can be completely deleted so it's no longer present, or partially deleted so a chunk of it is missing. So these are called structural variations, and there's a whole range of this, and this is a very simplistic understanding of the kind of variations that can occur. But I want to make that distinction between mutations and structural variations. So this is very recent research, and this is taking just the skin melanomas and the much rarer acral, the ones on the non-hair-bearing skin, and the mucosal melanomas. This particular analysis does not include eye melanoma, and I'll talk about that in a subsequent slide. But in this analysis, there's been an analysis of the frequency of mutations, that is, those single nucleotide variations, the small mutations, the letters being switched over. And you can see here, so here we have, these are all skin melanomas at the bottom, so that's all this lot, and you can see that they all vary, and they've been stacked up in order of how many mutations they've got, but the simple answer is all the skin melanomas have got lots of mutations, switching over of single letters. And the acral and mucosal, this lot here, have virtually none. Actually, if you look really hard, you can see that it's not zero, but the level of mutations is very, very low. And then here, this purple here represents the structural variations, those chromosome, the big things, the chromosome losses, duplication, switching, etc. And here you can see that there are many, many more chromosomal abnormalities than there are in the skin melanomas. It's not that there are none here, but there are more in these. So the pattern of mutation is different in the rare melanomas compared to the skin melanomas. And this comes from that same paper, and it's delving down into a bit more detail. And again, well, this lilac colour here, remember this is all the skin melanomas, this lilac colour is this. And all that is it's a particular letter switch over that typifies ultraviolet damage to in cells. So that's what that violet colour is, and you can see this is typical of the skin melanomas. And all these others, these are different substitutions in single letters, and the point I'm trying to get at here is it's different. So you get a much wider variation, and when you look at the signature that these have, and one can actually map these signatures onto particular kinds of ways in which DNA gets damaged, you can see that skin melanomas are damaged by sunlight, but actually in other melanomas, the rare ones, there's a whole range of different ways in which DNA is getting damaged. Some of them we don't really understand what those mechanisms are, but they're shared with other kinds of cancers. They're more like other cancers than they are like melanomas. That's really the point. And again, you can see that the frequency of mutations is much higher in the skin melanomas. Now that's important for a very important clinical reason. There is clear evidence that one of the reasons that melanoma responds to immune therapy is because it has a large number of variations within the cancer cell which can be chopped up and put onto the surface and recognized by immune cells as being different to the normal cells that the body is used to. So those single nucleotide variations, those mutations of substitutions of one letter for another, translate into the cancer cell being more susceptible to immunity. So the implication is that these ones here are potentially less visible to the immune system. We can wait 10 minutes, I think. Okay. So it has an implication in terms of the susceptibility to immune therapy. This is just switching over to ocular melanoma and giving the same kind of information. It's somewhat like the mucosal melanomas, that there's a low mutation burden. The pattern of ultraviolet-related damage is not found in ocular melanoma. It's slightly more complex than that. There's some variation. I mentioned before about the fact at the back of the eye there's ultraviolet exposure, at the front of the eye there isn't, and there is differences in the way mutations develop in the different part of the eye, but essentially that exposure to ultraviolet light inducing multiple mutations is not found in eye melanoma, whereas it is in skin. And there are these various structural mutations, of which I want to just highlight this monosomy 3, which is so that loss of one of the chromosomes is found in a significant proportion of ocular melanomas, particularly those that metastasize, and its relevance will come up a little bit later. When I was sitting after having had dinner, having come in last Thursday, having been very busy through the afternoon. I came in at gone 10 o'clock, had dinner, and switched on the television. And of course, what I was watching was the footage being beamed live from Newcastle and Sunderland. And you'll be aware, you remember, they were competing to see who announced the election, their local election first. And there's a very striking image, which was they had all their sports science students, and they were running with the ballot boxes to get them in fast. You've all seen that, I'm sure. And they were standing in a long line and passing them one to another. And that image stuck with me when I was drawing this diagram, because what I want you to think about is this signalling pathway, which was that you get this handing over of signals from one protein to another. And so connecting the outside of the cell to the nucleus on the inside of the cell and passing signals down in that manner. And it's like a bucket chain. It's not quite like a bucket chain. It's more like one here where they pass in particular kinds of molecules along the line. But nonetheless, it's passing signals from these various areas. And this is a very important pathway in how melanomas get driven. It's called the MAP kinase pathway, for what it's worth. And the key point I want to say is these proteins drive signals forwards, and these red ones are regulatory proteins that tend to switch the pathway off. And what I want to say is in skin melanomas, we're familiar that we get this common driving mutation called BRAF that drives it to activate this pathway. And also in many of them, we get this one switched off. It's lost, so it can't regulate this pathway, so that also becomes active. So that's the common pattern in skin melanoma, and it's a very highly druggable target. We know that because it's been activated, it can't be switched off, but then you can use a drug to target and switch that protein off. In many of the skin melanomas, but also in acrals and mucosals, but not typically in eye melanomas, this protein upstream is switched on, and that's a more difficult target to protein to target with drugs. So NRAS is quite common, and then we also see upstream of that in many of the acrals and mucosals and a few of the skins, c-KIT, this protein on the surface can be mutated. And this can be drugged, and there's a drug called imatinib and a whole range of proteins similar to that, which will target that. And indeed, I've treated people with imatinib for c-KIT mutated mucosal melanomas, and it has been dramatically effective, very rapidly shrinking the melanomas. Not a long-lasting effect, but nonetheless a very impressive effect that's produced good palliative benefit. In ocular melanoma, however, this protein's up here activated, and these have activating mutations in these G-coupled protein receptors, and these become constitutively active. And most ocular melanomas have one or other of these proteins activated. But again, these are somewhat difficult to drug, these, because what's happening here is a regulatory component of this is being switched off, so activating this pathway. That makes it harder to drug. I'm going to skip that, but that's seen in melanoma. But another thing in cutaneous melanoma is we have these regulatory proteins damaged or switched off in various ways. But in ocular melanoma, a different regulatory protein called BAP1, and this is on chromosome 3. Remember the one I said was lost in ocular melanoma? That is often lost, and so it loses its ability to have various effects that ultimately result in proliferation. So, what I wanted to get at with the biology is the variation. You saw the same pathway being shown there, but different ways in which the cancers have acquired the changes which result in their malignant properties. And that really matters in terms of the treatment pathway. So, I want to just change gear and just talk about pathways. Paul Nathan, who I may or may not be here, but is one of my colleagues at Mount Vernon, Paul Nathan had led a group, a national group, developing guidelines for management of ocular melanoma in the UK. And the key components of these are published, by the way, they're on the Melanoma Focus website and have been approved by NICE. The key focus is that these rare primaries need to be managed by 3 specialist units across the UK. They're not managed outside those units. And that there are pathways to develop identified prognosis. They should be formally staged, and they should be followed up for the primary at those sites. But then there also has to be a surveillance pathway for these patients because of the high risk of metastases In those guidelines, you will see there's very little consensus on the right way to do surveillance. And the evidence supporting surveillance is very weak, but nonetheless, people feel reluctant not to undertake surveillance for very good reasons. And there's also no real consensus on whether we can identify high-risk patients and focus all the surveillance on that population rather than on everybody. But nonetheless, that kind of pathway, that pattern of surveillance is what would be routinely undertaken. In terms of metastases, the real issue is that these people really do need multidisciplinary support and workup. So particularly because the liver is very heavily involved, very commonly involved, and often is involved as the only site or the first site of disease, then it does need sites which not only have access to people who know about melanoma, clinical and radiation oncologists and surgeons, but also hepatic surgeons, and the ability to undertake various different strategies to ablate disease in the liver and undertake proper risk assessment. And I'm going to run out of time to go into that in detail. But then also those regional centres need to be networked across the country so we can identify trials across the country. Because this is the key problem with ocular melanoma, is many of the treatments that we use for cutaneous melanoma are relatively ineffective for cutaneous melanoma. I'm going to have to move on from that slide and just really say for mucosal melanoma, it is a very different situation. So these come in through a whole range of different multidisciplinary teams in each regional centre, not even in a regional centre, but often in local centres, and are often managed in these small centres and really need to be captured and brought into the skin cancer setting. And we do not currently have good guidelines in the UK, but Melanoma Focus is developing them. But this is going to be a really challenging area as how to bring coordination for this group of patients with rare cancers. But broadly speaking, for these, they should be managed not dissimilar to cutaneous melanoma with an aggressive approach to resection, consideration of postoperative radiotherapy, and then there's questions marks about surveillance. And then skin management of metastases needs to come to an oncologist experienced in skin melanoma. And the last slides I want to finish before I'm being kind of kicked off the stage is really to these summarize the outcomes of the immune therapies. The simple answer is, I mean, you can read this for yourself. The simple answer is that if you look at the immune therapies in mucosal melanomas, the outcomes are not as good as for skin. You can see that for nivolumab, for the combination of the two drugs, or for IPI, the response rates are around about half. Complete response rates are lower. Progression-free survival rates are lower. And then there's this issue about PD-L1 or PD-L1 positive or negative, which we won't have time to go into. But again, one can use those markers. It is useful. But you are looking at, nonetheless, you're looking at a population generally who's responding less well to immune therapy than do skin melanomas. And for ocular melanoma, this is one paper, but there are various others reporting outcomes. But the key point here is using a bunch of different PD-1 inhibitors, nivolumab, pembrolizumab, and another one. The response rates are low, much lower than for skin melanoma. So it is this matches what we know about the mutation frequency. It really is very unclear that immune therapy should be standard of care in this setting. And survival rates are shown there. I'm going to finish, I think it's the last couple of slides. Am I allowed those? So just to finish, in terms of where the future might go, it is still very challenging. So it is about understanding the biology and trying to find new agents. There is no wonder drug on the horizon that I am aware of in any of these rare cancer settings. One of the more promising, perhaps it certainly was fated to ASCO, is one that I had some minor role in helping at the beginning, although I'm no longer involved in the trials. But is this one. This takes a receptor on T cells, on immune cells. It engineers it into a drug so that it can link T cells up with cancer cells, redirecting all your T cells that might be fighting flu or something else and redirecting them to attack the cancer cell. So, and this was explored in a phase 1 trial. And in the phase 1 trial, to find the right dose, a couple of responses were found in people with uveal melanoma, and so then the next trial, which was to investigate different prolonged dosing, that in that next phase trial, they recruited people with ocular melanoma. And although the response rate is pretty low, in fact, I think it's 0, the progression-free survival perhaps shows evidence of promise. So I think these now slides really were talking about various trials trying to target different components of this pathway. The key point is we don't yet have a drug in this setting that's coming out to that will be the obvious thing that we will all turn to. The work continues, and this just explores some of those possible issues. So I think I'll leave it on that slide, which I think is obvious what it all says, and take questions.